Okay, let us start with the next session. And the first speaker of the session is Dr. Göçe coming from Turkey. And he's talking about ICRS, perfect approach in complex, large, multiple stones with established indicators. Please.
Okay. Thank you, Dr. Rame, for the introduction, and I would like to thank the organizers and Dr. Zin, especially for this invitation and organizing such a great program. And I'm going to be talking about endoscopic combined intrarenal surgery for the management of these complex stones that we really see a lot in our daily practice. And just to start with the talk, I'd like to present you a case. This is a 36-year-old male patient presenting with left staghorn stone, and he has a right atrophic kidney that has a 14% function at the DMSA scan. And this is a young patient, a valuable kidney, a solitary kidney almost, so we need to tackle this case very precisely. And from my point of view, from the philosophy of surgery, actually, an ideal surgical technique for us should be successful, safe, and fast. And for the stone disease, what we can say is an ideal procedure should provide us the real stone-free status, not with clinically insignificant fragments, with minimal complications and minimal renal parenchymal trauma, and also with minimal operation time and minimal hospitalization time. And actually, mini ECIRS performed in supine position is the best option, in my opinion, to give us all of these outcomes. So first of all, I'd like to thank these gentlemen that provide us this technique today. Dr. Valdivia, who introduced the supine position first in 1987, and then Dr. Gaspar Ibarrazua, who just proposed the use of retrograde ureteroscopy together with PCNL in 2007, and Dr. Cesare Scafone from Turin, who just gave us the terminology of ECIRS in 2008 together with Dr. Gaspar Ibarrazua. And later on in the presentation, I'm gonna try to provide you the technical insight, how we do it, and what does ECIRS add to each part of the successful operation. First of all, to start with the patient positioning, this is our routine position, the Galdacao modified supine Valdivia position. What we do is we first of all mark the posterior axillary line and then put two bolsters, one under the hip and one under the chest, and just very slightly rotate the patient. Just 5 degrees is enough. I don't think that doing a rotation more than 30 degrees is necessary. And also we put the legs in the modified lithotomy position to make the retrograde access easily. And while doing that, for the contralateral leg, it's adducted and extended, and the contralateral leg is flexed and abducted. And this is a real-time video, just about 40 seconds, that we give the patient position. After marking the posterior axillary line, these two bolsters are put, one under the gluteus and one under the chest, and just very slightly rotate the patient. And please keep in mind that we should not pull the patient to the very edge of the operating table because there are metallic bars there and they're going to interfere with the fluoroscopic view. And then the legs are just put in the modified lithotomy position. And by just the help of one person, in less than 1 minute, we're going to do the entire operation in this single position. And of course, the operating room setup is also important. This is a case that we're operating the left side of the kidney, and we have two surgeons, and they have both their endoscopy towers just opposite to them. This one is the tower for the PCNL, and the other one is for the retrograde intrarenal surgery. The C-arm comes from the opposite side, and there is one scrub nurse, and she has two tables, and she is just assisting both of the surgeons simultaneously. And when you have a tower like this that you can have a split screen, then you can have more available space within the operating room. And now we just take the monitor of the C-arm to the same side, and again, just one nurse is enough in order to assist both of the surgeons. So to continue with the surgical steps, of course, our first step is doing the cystoscopy and ureteroscopy and the retrograde pyelogram. And actually having access from the distal urethra to the most upper calyx is important during the surgery because we dynamically and endoscopically just see the whole collecting system. For example, we may see some very small tumors within the bladder or in the ureter. There may be some strictures in the ureter or some other ureteral stones, and we can just treat them in one session, in one setting. And also we can do the retrograde pyelogram through the working channel of the flexible ureteroscope and continue with the rest of the procedure. And after doing the retrograde pyelogram, the next step is, of course, doing the puncture. We all know the puncture methods in PCNL. However, what does ECIRS add is the endoscopic guided puncture. We first evaluate the entire collecting system with the flexible scope and choose the most appropriate calyx for us to puncture that will lead us to the dominant stone portion, and then make the access under direct endoscopic vision. And by this way, we can make 100% sure that we are in the correct calyx in the collecting system. And we can further proceed with the dilation and sheath placement, again under direct endoscopic vision. And this will provide us less fluoroscopy times together with maximal security. So this is another example that we did the entire tract creation under endoscopic control. We are making sure that we are in the desired calyx. The guide wire is coming, and you can even take it out through the urethra if you need a kebab patient with the help of a nitinol basket. Now the dilator comes in, and we just see it endoscopically very beautifully. Of course, this is not always possible because we are talking about complex cases, and in those cases, the stones actually just fill the collecting system, fill the entire calyx, so you may not see the needle or the dilator. However, you can make sure that it's there because the stone will move still, and also the irrigation fluid through the flexible uteroscope will distend the system, and it will ease your access. And after creating the tract, the next step is, of course, fragmentation of the stones and taking them out. And in this manner, what ECIRS gives us is we can treat multicalycial stones from a single tract with the help of the technique of passing the ball. So this is the example. The right-hand side is the view from flexible scope, and the other one is the mini nephroscope. We are operating on the right-hand side. We made a lower pole access and treat the stones in the lower pole and the renal pelvis, and then we have some other ones in the upper pole. And they are fragmented with the holmium laser via the flexible uteroscope, and then we take the fragments out of the system with the help of a nitinol basket from our percutaneous tract. So in one shot, from a single tract, we treat all of the stones in the entire collecting system. So this minimizes the amount of renal parenchymal trauma and also minimizes the amount of bleeding. And this is another example. Again, now we are on the left side. This is a retrograde pyelogram, and all of the filling defects are huge stones. So what we do is we create the access and then make here a 24 French access and treat most of the stones in the middle pole and the renal pelvis. However, there are some other stones located in other parts of the collecting system. So this is the view from the flexible uteroscope from the upper pole. There are a lot of fragments. We are taking them into the renal pelvis one by one, and then take most of them with the vacuum cleaner effect, and some bigger ones, we just do some ballistic lithotripsy very fast, and all of the fragments are taken out of the system. Together with that, we also check the entire collecting system, the other parts of the calycial system for any residual fragments, and this actually avoids just one more tract in the upper pole that may lead us to significant bleeding, pleural injury, and anything. So this is not an innocent procedure, but still we just limit the amount of complications. And this is the end of this case, a lot of stones, and we did an antegrade pyelogram at the end of the surgery. As you can see, there is no problem, and all of the stones are cleared. So how about the scientific data? What does it say? This is our own data. Actually, the aim of this study was to compare spine and prone positions for management of real staghorn stones. In the end, we find that between the positions, the stone failure rates were similar. However, supine position adds us the benefits of, first of all, we need less multiple punctures, less multiple tracts. We don't need we need intercostal punctures less because we don't need those upper pole punctures. And also it just limits the amount of bleeding together with the shorter operation time. And all of these three benefits, less need for multi-tract, less need for intercostal punctures, and less bleeding comes from the simultaneous use of flexible ureteroscopy because it limits the necessity of multiple tracts. And at the end of the procedure, after clearing all of the stones, of course, before ending the procedure, we need to evaluate the collecting system for any residual fragments. This is one of our main problems because the stones can migrate to other parts of the collecting system. So we evaluate it with the fluoroscopy, but we all know that it's not so specific for detection of the residual fragments. It's not so, precise. So we usually try to evaluate it with our endoscope, with our nephroscope, and in order to do that, we can either use our rigid nephroscope or we can use flexible nephroscopy. But in my opinion, in the modern and the urology, we need to have those flexible scopes always in our operating room, always in our operating tables. And we can do this flexible nephroscopy either via the percutaneous sheet or with the retrograde access. It's possible for both options. However, in another study, we compared using the doing the flexible nephroscopy either antegrade or retrogradely and published our outcome. And this study, we have 137 patients, all underwent ECIRS for complex stones. And in the end, in all of the patients, we did a postoperative non-contrast CT scan to evaluate the outcome of the surgery. And what we did was, at the end of the operation, we first made an antegrade flexible nephroscopy through the percutaneous sheath in every patient, and then repeated retrogradely, again in every patient, and compare the results. And we find that in about 95% of the cases with the retrograde access, we can navigate the entire collecting system. But it's not the case for antegrade. In about 25% of the cases, we were not able to reach all of the calyces with the antegrade approach because if you have a parallel calyx, then your flexible scope cannot rotate back and see that. Or even you see something there, you cannot take it out, or you cannot laze it with that deflection. That's the problem. So doing the retrograde approach provided us seeing the entire collecting system, and also we find residual fragments in 18% of the cases. So it gives us also the opportunity to treat those residual fragments. And also we compared the results with the non-contrast CT scan, and the negative predictive value for retrograde flexible ureteroscopy at the end of the procedure for detection of any residual fragment is more than 96%. So if you did a retrograde flexible ureteroscopy nephroscopy at the end of the procedure, you can avoid a non-contrast CT scan in the postoperative follow-up. This is the main benefits. And this is how we do it. This is a 65-year-old female patient, and she has stones in the middle pole and also a huge stone in the mid-ureter on the left-hand side. So in this case, we started with the retrograde ureteroscopy and just laser and pushed this stone into the kidney, then made a middle pole puncture and treated both of the stones. And this is at the end of the surgery. The middle screen is for the flexible ureteroscopy, and we are just searching the entire collecting system for any residuals. And this is the only way that you can make 100% sure that there is no residual fragments. So of course, this is a really nice surgery. If you have the opportunity, you can do that. But of course, there are some drawbacks. And most important drawback, of course, comes from the cost. The flexible scopes are expensive, not readily available everywhere. You need 2 towers, you need 2 surgeons, you need available space in the operating room. And it's really hard to do in the prone position. It's possible. The people in the American school, they do it with the prone split leg position. However, it's just doing something very easy, doing in a hard way. So doing in supine position is better. And of course, one of the most important problems is the reimbursement because we are not paid separately for the ECIRS. Mainly we are paid for PCNL, so doing the RIRS together with that procedure just comes out of the hospital's pocket. And in the end, I just want to go back to the first case that I mentioned at the beginning of my presentation. In this case, we first did a middle pole puncture with a 16 French sheet. There are multiple stones in the system, and they are just taken out with the vacuum cleaner effect. And then there's the huge stone in the renal pelvis, and we just fragment the stone with the ballistic lithotripter very fast and efficiently and take those stone fragments out. and most of the middle pole and the pelvis is now free. And then there are some stones in the anterior calyces, and we just use the pass-the-ball technique to prevent the necessity of an additional track there. And these stones are also taken out. But then we make the puncture to the upper pole, the second one, because there's a huge stone burden there. So what we did was 2 tracts, ECRS, 1 mini and 1 24 French tract. And we do the ballistic lithotripsy in the upper pole for those fragments. And these are all, again, taken out without the need for any basket or any disposable. They're just washed out of the system. And in the end, this was a solitary kidney, and we tried our best to minimize amount of renal parenchymal trauma. And in the end, again, just evaluated the entire collecting system with the flexible scope for any residual fragments. And in the end, in my hands at least, this was the best that we can do. So to conclude, as I mentioned, the ideal surgical technique for stone disease should provide the real stone-free status with minimal complications, minimal parenchymal trauma, and minimum operation time. And in this manner, doing an ECRS in supine position, especially with the miniaturized tracts, gives us all of these opportunities. And I'd like to thank you all for your attention.
Thank you very much for your presentation. Are there any questions from the auditorium? Yes, please.
Thank you, Dr. Gochi, for your excellent talk. Naturally, combined surgery is safe and fast to get clearance, fast clearance of bulky stone. But honestly, I think that the cost is very real limitation for the use of this technique in developing country. And second question, don't you think that the use of nephroscope, flexible nephroscope through access sheet is more faster and more cost effective than passing flexible through ureter and using access sheet?
Okay. Actually, from the budgets, I can say nothing. It's there. It's an expensive procedure, of course, and it's the main drawback. But if you have the opportunity, then it's better to use it. And using the flexible scope from the percutaneous sheet, it's technically something challenging because, first of all, if you are doing a mini PCNL through a metallic sheet, I do not recommend to use your flexible scope from there. Because if you have a fiber optic reusable one, you will break it. I have done it. And if you do so, use a single-use one. It's better. Or if you have a bigger sheet, an M+ one, then you can use the flexible cystoscope through your percutaneous sheet. It's a better option, and because it has a shorter flexible tip, and it's better to manipulate. However, the main problem is you cannot reach the entire collecting system with the flexible scope from the percutaneous sheet. When you do it retrogradely and you fill the collecting system with your nephroscope as well, then it's easier to navigate. The problem with the antegrade approach is the collecting system also gets empty through the percutaneous sheet. You cannot fill it, so that as it collapses, it's also hard to see the entire collecting system. That's one of the other problems. I mean, if you are using a 9 French flexible ureteroscope through a 16 French sheet, then the system will collapse. Your irrigation will not be sufficient. That's another technical point.
Yes, Sanjay, please.
Okay, that's a very nice question. Honestly, after I started doing supine, one of my main motivation was to do ECRS. And first of all, I kept it for the challenging cases, for the multicalycial stones, etc. And now, for every case, I have the flexible scope readily available in my operating table. And my technician and nurse just asks now if I prepare flexible scope or not. It's not the question. Which one should I prepare? Reusable or the single-use one? That's the question. So I now try to do ECRS for every case. But of course, it's just an opinion, not a general indication.
There's another question over there,
Yes.
please.
Mr. Mohan, congratulations for this comprehensive presentation. And I ask you, for this PCOS, is it pre-planned? You say that for this patient, I will do it, or just on the go, you have your flexible uteroscope, and in case of difficulty to track the stone in the kidney, so you use the PCOS. You pre-plan or just on the go?
So it depends on the particular case that how we do it. For example, if you have a stone occupying the renal pelvis, a huge one, an impacted one, then so starting with the flexible scope has no benefit because you will not see anything. You just see the UPJ and stone there, and you just force your flexible scope and you'll just break it. So instead, we just continue with doing a standard perk, and then after clearing the renal pelvis, if there are stones in the other parts of the collecting system, then insert the flexible scope from below. But in some cases, we have multiple stones in multiple calyces. So at that time, it's better to start with the flexible ureteroscopy initially, because some of the fragments may navigate from kidney to the ureter after your imaging to the operation. Sometimes it takes more than a month. So just evaluate the ureter for any stones, and then navigate the collecting system and select the best calyx that will lead you to the most stone burden, and then do the puncture under endoscopic control if possible. So it just depends on the particular case.
A question to Sanjay. Sanjay, you prefer the prone position. Are you ready to switch on to relearn PCNL in supine position to do this?
The question I asked to you, the indication for the ECIRS. So basically you do when there is a multiple stone, right? I choose mostly, that is about 70% of the puncture is through middle calyx. The reason you use flexible is to find the different calyceal stones, right?
Mm-hmm.
But if you go through the middle calyx, mostly these kidneys bearing with the multiple stones are hydronephrotic.
Mm-hmm.
When you enter from mid calyx, you can easily inspect the lower pole group calyces easily without much difficulty when you use the mini PCNL technique. Anterior, posterior, or inferior. Very easy. So mini PCNL, when you do it, you can minimize the multiple tracks and you can avoid the ECRIS.
Yeah, I could totally agree with you in this manner. I mean, it's also our main practice to do a puncture from the middle pole, and at that time, you can navigate the lower pole and the upper pole, but not all the calyces. That is what I mean to say. For example, in supine position with the study of Mario Sofer that we saw yesterday, you can navigate the upper pole through a lower pole puncture, but it doesn't mean that you reach all of the calyces. That's the problem, and that is what we saw in our study.
The main concern about ECRRS is the addition of morbidity because you have two accesses to the kidney. You did not talk about the morbidity. Please, would you tell us something about this concern?
Okay. Actually, I totally agree with this point as well, because I personally believe that kidney stones are the disease of the kidney. So it should be treated through the kidney. I mean, passing through urethra, bladder, and ureter, it just increases the morbidity of the procedure. I totally agree with that. However, in most of the cases, we also treat those stones with the retrograde ureteroscopy. And of course, it may have some potential to harm, especially the ureter. And that's why in most of the cases, I avoid using a ureteral access sheet. But with those now, the tiny scopes with the 7.5 French or 8.5 French, we can do that. I mean, so it's basically, we should personalize the treatment options for every patient. But in the end, we should balance which one is more morbid, leaving a residual fragment behind or doing a retrograde ureteroscopy to treat it. I mean, we should balance the cost and also the benefits of these procedures. I totally agree with your comments. It's quite right.
I just want to clarify another point. I think we should not talk about the costs because our aim is the benefit of the patient and not a cheap operation. The costs are associated to the equipment we are using, the costs for the operating theater. We cannot influence them. If we are talking about money, we should talk about the reimbursement, not about the costs, because we have no possibility to change the costs.
Yeah.
And if we are talking about reimbursement, this is very difficult because reimbursement is associated to the particular country. I already mentioned in Germany, ECIRS is impossible. If you do this, you can close your hospital after a few months because it is too expensive. Not too expensive, it is associated with less reimbursement. This is the difference. How is it in Turkey?
Yeah, actually, there's no separate reimbursement for ECRS, of course, and we are just charging the social security system or the insurance company for PCNL and RIRS together. And it, depending on this, their contract, they either pay for both of them or just for the PCNL as it is more expensive. So if in that case, we are just paying RIRS from our own pockets.
Okay, Dr. Pal?
See, the basic thing for doing ECIRS, you have to pass the flexible scope through the infundibulum to the inaccessible calyx. So infundibulum has to be wide enough. If the infundibulum is narrow, you cannot reach up to the stone through the flexible scope, and you have to do a mini PCNL. Point number 2, if the infundibulum is wider, since last 30 years I have been practicing saline push technique. I will puncture the most lateral aspect of the stone, and with 20 ml saline push, that stone through the wide infundibulum will come into the renal pelvis and in front of your big implant sheath. So I have never used or never felt any indication of ECIRS. If the infundibulum is narrow, you have to make a mini PCNL track or a ultra mini PCNL track. And if the infundibulum is wide, then why not push it in front of you? I will be showing in some of the saline push technique in my next lecture. If you follow that technique, there will not be a need of ECIRS.
Yes, now we had a very long discussion about the indication of ECRS, and now I have a question to the auditorium. Do you think that, or I have to say it in other words, are you in favor of ECRS, or do you think ECRS is not necessary? Who is of the opinion ECRS is not necessary? Please raise your hands. And who is in favor of ECRS? Yes, but where are all the other surgeons? Don't they do any operations? They're sitting 50 people. No, this is not a good data collection. We should repeat this. Now everybody is really asked to raise his hand or not. First, who thinks that ECRS is not necessary? Okay, and now those who are in favor of ECRS? Yeah, there's some more. Thank you very much for your presentation.
Okay, thank you.
Okay, so far as I heard, the order of the presentation has changed, and your next presentation would be about the use of thulium fiber in RIRS. How will it affect the PCNL applications in the near future? This is the next topic.
Yeah.
Please.
Thank you so much again. So just to continue with the polls, how many of us in the operating room have available TFL laser in the operating room? Dr. Paul and no one else. So actually, TFL is a novel technology, and just to start with the EAU guidelines, we all know that we spare the PCNL for stones greater than 2 centimeter, and also the ones that we cannot treat retrogradely, the smaller ones that cannot be approached through the ureter with respect to the pelvic calyceal anatomy and some other problems. So today's question is mainly, does TFL will let us treat bigger stones with the flexible uteroscopy? Is it the question? So just to start with that, first of all, I would like to give some basic information about the lasers, the differences between holmium and thulium fiber. And this is the basic structure of the holmium yak laser. What we have is we have a flash lamp. It just emits the light, and then we have the laser rod that's actually the amplifying medium, and it just changes the wavelength of the light because there's an atom inside this amplifier, and the wavelength of the holmium yak laser is 2100 nanometers. And now we have a lot of high-power holmium lasers available in the European and also Middle East markets, and they give us really very nice properties. They can go as low as 0.2 joules to as high as 6 joules of energy, and it can go up to 100 and 120 hertz of frequency with some devices, and we can really reach some long pulse durations with these holmium yak laser devices. Together with that, we have some new generation devices that give us the ability of pulse modulation. This is the one Moses effect from the luminous laser, and also we have some similars from Quanta, like the virtual basket effect. And these pulse modulation systems have some technical properties that give us to better dust the stones or use it more efficiently for prostate enucleation as well. So in the end, a holmium yak is actually in most of our operating theaters now, and it's a very versatile laser. It can enucleate, it can cut, it can coagulate, it can fragment the stone, it can dust the stone, so it gives us actually all. So what does the difference between holmium yak and this thulium fiber laser? First of all, just as a small point, the TFL laser is not the thulium yak laser. It's totally different technology. This is a pulse laser, and now instead of those flash lamps, now we have the laser diodes, and the light coming from these diodes are combined, and then they are given to an amplifying medium again. But this time, it's not a rod, but it's a fiber. That's why we call it thulium fiber laser. And there are thulium ions that are doped into this fiber, and then it changes the wavelength of the light, and it's about 1940 nanometers now, and then it's just connected to the passive fiber, and we have the energy. So from the technical point of view, when we compare these two technologies, thulium fiber laser is a smaller device, it's much more lighter, and it doesn't need a special electric supply. We usually use 200 micron fibers with the TFL now, but it can go as small as 50 micron. It's an important property. And regarding the energy range, the maximal energy is not different between the two lasers, but the minimum energy is much more lower in the TFL. And in terms of frequency, it can go up to 2400 hertz, but of course we don't need it. And another very important property is the pulse duration. With the high-power holmium yak lasers, we can reach 1700 microseconds in the holmium, but with TFL, the pulse duration is much, much longer. And also, the wavelength is different that I'm going to mention later on. And also, pulse shape is more uniform in the thulium fiber laser. It means that you do not have a peak energy that causes stone retropulsion or involuntary fragmentation. So this is what we talk about the wavelength. And when we compare these two, the wavelength of the TFL is just very next to the maximal absorption by water. And therefore, TFL is 4 times more absorbed by water than the holmium yak. And therefore, the optical penetration depth is higher for holmium. It's just lower in the thulium fiber laser. And this is the example of the pulse shape. The one at the top is for the TFL. As you can see, it's very uniform. So with the holmium, we have some peaks, and this really causes the better stone fragmentation, and sometimes it's involuntary, and that we do not want during RIRS. So for the differences in clinical application, thulium fiber laser gives us less peak power, lower energy with higher frequency, with longer pulse duration, with a more uniform pulse, and of course gives all of these with a smaller fiber. So it is a better laser for dusting the stones. However, we have some technical problems with RIRS, and the question is, does TFL solve all of these? In RIRS, what we need is a fine dusting. It means that really sub-millimeter fragments, a fast dusting with high frequency, and while doing that, we need good irrigation because it will provide good visibility. And in the end, at the end of the procedure, all of these fragments should pass spontaneously through the ureter. It's our main aim. So does TFL solve all of these problems? Actually, it provides us low energy, longer pulse duration, and a uniform pulse shape. So with the smaller fibers, we can have a good visibility. But how about the literature? What does it say? Now, the thulium fiber laser is in market after 2018, and now our experience is growing with during flexible ureteroscopy with TFL. And this is a nice study, a prospective randomized study comparing PCNL and retrograde internal surgery for stones greater than 2 centimeters now. It's the topic of today's talk. But in this study, the authors used holmium yak laser, and we can see that the mean operative time is 95 minutes. In flexible ureteroscopy, we usually try to limit our operating time less than an hour, so it's a long operation. And in the end, the stone-free rates is about 70%. It's not sufficient. And together with that, in 13% of the patients, there is postoperative fever. So from my point of view, these results are not acceptable. This is not a treatment success. So treating stones greater than 2 centimeters with holmium yak is not a good option. You will need multiple procedures. And this is another study comparing the ultra mini and RIRS now. And again, the lithotripsy is performed by holmium yak laser, and the stone diameter is 1 to 3 centimeters. And again, the operating time for the flexible ureteroscopy is more than an hour. It's again not acceptable, and the stone failure rates are lower than PCNL. And now in this study, the incidence of fever is 22%. It's quite high. And this is this study by Dr. Chandra Mohan. This is a very interesting study. They just gave us the data with thulium fiber laser during RIRS. And now the mean stone size is 50 millimeter. And now, as the stone size is smaller and the expert is doing the surgery, the stone failure rate is now over 90%. But still, the complication rates are high. And in this study, very interestingly, they also evaluated the laser efficiency, and they find that the ablation speed increases with the higher stone volume. And they say that the bigger the stone, the lesser the energy required per cubic millimeter of the stone. So it means that if you have a big stone, it doesn't go anywhere, and you can just paint the stone much precisely with your thulium fiber laser. But of course, this requires a nice flexible ureteroscope as well. You need a digital scope to have that good visibility. And our Russian colleagues, they have the most experience also with the thulium fiber laser, as this laser originated from Russia. And in this study, Enikiev and his colleagues compared the RIRS and PCNL. Both of the groups were operated with the thulium fiber laser. Now, the important thing is the mean stone density in both groups is less than 900 Hansfield units. So they are treating the softer stones here. The mean stone size is more than 2 centimeters, and the median laser on time is about just 10 minutes. It's really interesting. It means that they are using the high frequency settings probably because it's really very fast. And in this study, they also evaluated the difficulties in visibility. I mean, with such stone dusting with high frequency, the vision really gets blurred due to the stone dust. And they reported it in both RIRS and PCNL. And we can see that in 14 of the RIRS cases, in 3 of them, there was problem with visibility. So to show my personal experience on that, this is a study that this is a case that we performed endoscopic combined intrarenal surgery, and this is the view from the nephroscope, and we are just doing 0.2 joules through the flexible scope. We are trying to do the dusting, and as you can see, we have continuous flow from the sheaths, and still the vision is getting blurry. Although we have nice dusting, it's getting blurry. And also another problem with TFL is it makes sometimes this stone charring. There are some black dots, and then it becomes impossible to make the dusting. So we just shift to the fragmentation mode, and this laser is not as efficient as holmium yak laser for stone fragmentation. It's better for dusting, but it's not good for fragmentation because it has a less peak power. So if you're doing a mini PCNL, in my opinion, having a holmium yak laser is better. But if you're gonna do RIRS with fine dusting, then RIRS is a better option. So to conclude, first of all, we should know that TFL is a novel technology. It's different from both holmium yak and thulium yak. But in my opinion, it's somehow overrated technology. It doesn't solve all of the problems of flexible uteroscopy. It's more efficient than low-power holmium in most of the settings, but we need comparative studies to compare it with the high-power holmium yak lasers, especially with the pulse modulation, also for flexible uteroscopy. The other one is, does RIRS with TFL can replace percutaneous nephrolithotomy? I mean, TFL doesn't solve all of the problems of the RIRS because the main problem is reaching the collecting system and having a low intrarenal pressure and also extraction of the residual fragments. These are all problems. And also, if you have a tight ureter or an inaccessible lower pole, then TFL again doesn't solve these problems. And again, RIRS is an expensive procedure. You still need a lot of disposables when you treat it retrogradely. And so, what is the future of PCNL? Does RIRS with TFL replace PCNL? I can say that PCNL is here to stay. When you have a huge stone burden, when you cannot access the stones with the retrograde access, if you have a narrow ureter, then PCNL is still the best option. And also it provides immediate stone clearance. You can just send the patient out of the operating room without any residual fragments with PCNL. And I guess miniaturization together with active section is the future of PCNL. But still, the final word is we should personalize our treatment options for every case, with taking into account the stone-related factors, the patient anatomy, and the social factors that are included for our every individual patient. So personalized stone approach, the PSA of endourology is here to stay. Thank you for your kind attention.
Thank you very much. On va prendre une seule question, si vous le permettez, parce que le bloc opératoire est prêt et on va commencer la transmission. Donc, une question dans la salle. Just one question.
Please, I have two questions. What about risk of injury of ureter with hyperthermia with thulium laser? And second, Traxer talk about suction aspiration system for ureteroscopy. What about this?
Yeah.
Thank you.
I mean, as you know, the Olympus company released a notification for the thermal injury, and the problem is the device comes up with the factory settings for doing the procedures. I mean, we should always respect the settings while using TFL. But the main idea is, I don't believe that TFL creates an extra risk for thermal injury, not in addition to holmium yak laser, because what provides heat is the total watts that you use. So if you are using the same energy and same frequency, then you're going to have the same watts for both holmium and thulium. So you should respect with both of the lasers. If you increase your frequency, then you increase the watts as well, and also you may not control your device very well, so it may end up with thermal injury. So the main idea is just not to go up to 10 watts in ureter, and more than 20 watts in kidney. So if you are just below these thresholds, I don't think that there will be any problem. And if you are using high energy or high frequency, what I do in my daily practice is not to just use irrigation fluids in the room temperature. The chilled irrigation can prevent it, I believe, but I don't have any data. But in my personal experience with TFL, I don't think that it doesn't cause additional thermal injury.
On apprend à l'instant qu'il y a des problèmes de connexion avec notre ami chinois, donc la porte est ouverte à plus de questions, donc allez-y. More questions, problem of connection. Yes.
Thank you very much. May I know your opinion on use of TFF-RIRS in stones with the 100,000 on-suite units?
Okay, so actually most of our patients in Turkey also have dense stones. So with the whole mimiac laser, we cannot dust these stones very efficiently. There are always some fragments scattering everywhere during RIRS, and that's the main problem. And with thulium fiber laser, it's better, you can dust those stones better, but in the end, during lithotripsy, there are, as I mentioned in the video, some black dots appear inside the stone, and then it just becomes something sticky or rubbish structure, and you cannot further continue. So you need some fragmentation in the end. I mean, it doesn't really very efficiently solve the problem, but maybe we can still adjust our settings. And while doing that, actually, what I could recommend is using a short pulse. With the long pulse of the thulium fiber laser, it's really harder to make the stone dusting. But the short pulse duration of thulium fiber laser is already so longer than that we have in holmium laser. So you should just try to adjust your laser settings to get those stones better dusted. But it's not good for fragmentation.
Mehmet, I'm sorry, we just have to stop the discussion.